Hello everyone, Assalamu alaikum. This is bladder tumors part 4. We'll speak about the stage TA, low grade tumors. Okay, 2RB, try to eliminate all grossly visible tumor. 2RBT, immediate postoperative intravascular chemotherapy, a single dose of intravascular chemotherapy applied within 24 hours of TURBT, ideally with 6 hours, but it's usually within 24 hours, but ideally with 6 hours. It's recommended because it's reduced the risk of recurrence, absolute reduction of recurrence 14% in 5 years recurrence. Okay, so it's this chemotherapy within 24 hours is recommended, and ideally it is within 6 hours. Induction of intravascular therapy. When risk factors for the recurrence are absent, avoiding induction therapy is reasonable when the risk of recurrence is low. Option includes surveillance versus intravascular induction chemotherapy. When the risk factors for recurrence are present, consider administering a 6-week of induction of intravascular chemotherapy starting 3 to 4 weeks after TURBT. And when any of the following risk factors are present, if we have a multiple tumor or a recurrence of the tumor within 1 year, or we have a large bladder tumor, example that's more than 3 centimeters. For low grades, TA tumor chemotherapy is preferred over BCG because the toxicity is less and the risk of the tumor progression is low. Okay, this is for low grade TA. The chemotherapy is preferred. Okay, the chemotherapy for low grade T1 TA is preferred compared with BCG because the toxicity is less and the risk of the tumor progression is low. BCG may be considered for high-risk cancer such as diffuse tumor with multiple risk for a recurrence, example, several tumor more than 3 centimeters, or a rapid recurrence after previous intravascular induction chemotherapy. Surveillance or office validation of recurrent tumor. This is only an option when all of the following criteria are met. If we have the patient have history of only low-grade TA tumors that have been confirmed pathologically. That means no history of high-grade or stage more than T1 tumor. This is considered the first. Then the urine cytology show no high-grade cells, or the recurrence tumors appear to be viewed in numbers that less than 1 centimeter in size, low-grade tumor, and stage TA. Example follow-up regimens for the patient with low-grade TA, cystoscopy at 3 months post-TUR, then at 12 months post-TUR, and then every 12 months. Okay, so this is a good example for the regimen for TA low-grade tumors of the follow-up. What we will do, we'll do cystoscopy at 3 months post-TUR, and then every 12 months post-TUR, and then every 12 months post-TUR for the patient with low grades. Urine tumor marker are not recommended for follow-up of the treatment of stage TA low-grade tumors, but cytology should be performed for surveillance of an untreated tumor. So untreated tumor, we will do urine cytology for surveillance. CT urogram when there are frequent recurrence or when symptom develops that may be cancer-related gross hematuria or flank pain, we will do CTU. CT urogram is preferred in most cases, but the other regimens alternative are available. So CT urogram is the best. Then we come to stage TA high grade. Stage TA high grades, the TURB as option if high-grade or invasive bladder cancer is suspected. Okay, TA high grades or invasive, resection should be deep enough to remove the muscularis proberia, except when the cancer is in diverticulum, we speak about the cancer. For the tumor in diverticulum, already we discussed this previously in the previous lectures. Restaging TURBT. Restaging TURBT within 6 weeks after previous TURBT is an option for all patients with TA high-grade cancer, but it is strongly recommended for any of the following situations to do restaging. If the patient had period resection did not remove all grossly visible tumor, if the period resections did not contain muscularis proberia, except when the cancer is in diverticulum, or the tumor was larger or multifocal, larger than 3 centimeters, or multifocals. Immediate post-operative intravesical chemotherapy, a single dose of intravesical chemotherapy within 24 hours of TURBT is also option. Ideally within 6 hours is recommended because it reduces the risk of recurrence. Absolute reduction 14% in 5 years recurrence, as well as in the patient with low-grade TA. The period resection did not contain muscularis proberia, except when the cancer in the verticulum and the tumor was large more. This is also induction. Administration should be 6 weeks induction of the course intravesical therapy, preferably for the patient with TA high grades to give induction of BCG starting 3 to 4 weeks after TURBT. BCG is preferred for high grades TA tumors because it is more effective at preventing recurrence and progression than chemotherapy. Intravesical chemotherapy may be used for induction, Intravesical chemotherapy may be used for induction when the BCG is not feasible. 6 weeks after finishing a 6 weeks induction course, perform cystoscopy with or without biopsy and bladder wash cytology to check for persistent tumor. If TURB after 6 weeks induction course show that high-grade T1 cancers, then radical cystectomy is preferred management. If TURB after 6 weeks induction course show persistent TA tumor, low-grade or high-grade, that's persistent, any of these tumors, low-grade or high-grade TA, or no tumor, the treatment typically consists of second 6-dose induction course of intravenous BCG, intravesical BCG. 6 weeks after finishing the second course of BCG, perform cystoscopy with or without biopsy and bladder wash cytology. If 6 weeks course of intravesical therapy fails to eradicate the tumor, the option includes cystectomy or change to a different intravesical agent. Maintenance BCG if a tumor is eradicated after 1 or 2 weeks course of induction therapy, then maintenance BCG is recommended. Example of follow-up regimens after BCG, after induction of BCG, cystoscopy and urine cytology. For intermediate risk cancer, cystoscopy and urine cytology at 3 months post TURBT, then every 3 to 6 months for 2 years, and then every 6 to 12 months for 2 years, and then annually. This is for patients have intermediate risk. For high-risk cancer, cystoscopy and urine cytology at 3 months post-UR, then every 3 months for 2 years, and then 6 months for 2 years, and then annually. Using other urinary tumor marker is an optional. CTU every 1 to 2 years, every 2 years may be more appropriate for intermediate risk cancer, where every years or more be appropriate for high risk and very high risk cancer. CT urogram should also be performed when there's more frequent recurrence or the patients have symptoms of cancer of symptom related to the cancer like gross hematuria or flank pain due to compression to the ureter. CTU is preferred in most cases, but other imaging alternatives are available. This is the end of bladder tumor part 4.